Welcome, everyone. My name is Zsolt Huszár, and my PhD topic is about the risk factors of cognitive decline in elderly population. I work as a psychiatry resident in the Department of Psychiatry and Psychotherapy Clinic at the Semmelweis University. And our vision is that in the future, the cognitive decline will be avoidable by the widely used prevention programs. That's why our mission is to assist in the development of the prevention programs. Here you can see our two specific goals. First, we would like to evaluate the association between the pathological change, the typical pathological change of the Alzheimer's disease and the rate of cognitive decline by our meta-analysis. And second, we would like to estimate the relevance of the relevance and the biological effects of different risk factors of the major neurocognitive disorder. The title for meta-analysis is the rate of conversion to dementia in the MCI and the healthy population with abnormal amyloid levels. We currently work to finalize our results. We have some issues about how to pool our data from the articles because they expressed their outcomes in very different ways. Yes, that's where we are. And about the background, from 2019, the American National Institute on Aging Alzheimer Association has defined the definition of Alzheimer's disease by purely biological changes. The diagnostic criterion is the beta-amyloid and the phosphorylated tau accumulation in the central nervous system. These two proteins is responsible for the two known pathological changes in Alzheimer's disease, the senile plaques and the neurofibril tangles. But I would like to emphasize you that this is a recommendation for researchers, not a diagnostic definition for clinicians until now. These lesions play a central role in development of Alzheimer's disease, but it's not clear to what extent the presence of these lesions accelerates the cognitive decline. That's why our question is, what is the prognostic role of these two changes on the conversion rate of cognitive decline? We investigate two different populations, the cognitively unimpaired subjects and patients with mild cognitive impairment. They are the so-called MCI population. And the exposure, of course, these two mentioned changes, and we compare the lack of it. And the outcome is the conversion rate of cognitive decline. Here you can see our systematic search and the flowchart selection. In the end, we had 207 eligible full text. And here I present you our first forest plot, which is about the conversion rate from MCI to Alzheimer's dementia in beta-amyloid positive subjects. You can see the heterogeneity of the population is moderately low. And between the studies, you can see, I don't know how to point, so you can see between the studies the ADNI, which is the Alzheimer's Disease Neuroimaging Initiative, which is the largest database in the world. We have direct access for their data, so we previously exclude the articles which use their data, and we use their data directly and pooled with the other articles. So you can see that the effect of the pathological amyloid level is high, but you can remember our question was how it accelerates the conversion, and based on this forest plot, our answer is the hazard ratio of the conversion to dementia from MCI is 4.5 higher in the amyloid positive group compared to amyloid negative groups. The further outcomes, what we are looking for, the conversion regarding both the amyloid and phosphorylated tau levels, and we also would like to investigate not just the conversion from MCI to dementia, but the cognitively unimpaired subject to MCI. To summary, this is the only systematic review in the field, and the meta-analysis summarizes different amyloid measurement techniques. There are two kinds of techniques. Some where they measure it directly from the cerebrospinal fluid, other were by a PET-CT scan. This is both the limitations and the strength, because these are the two use techniques, but by measuring the amyloid levels by a PET scan, it's much more sensitive, so it also could be a limitation of this study. The other limitation is the incidence of other risk factors is not known, like the late-onset depression, the diabetes mellitus, which are also serious risk factors. And regarding the cognitively unimpaired group, in most of the studies, the cognitively unimpaired group had some subjective but not measurable cognitive complaint. So our conclusion until now, that the abnormal beta amyloid levels greatly accelerate cognitive decline in MCI population. That's why our recommendation that to start the pharmacological and non-pharmacological treatments should be related to amyloid status, not the cognitive status, because until now, we can start only the pharmacological treatment when the patient gets the diagnosis of dementia. But obviously, it's much later than the cognitive decline is started. And the implication for researchers that the efficacy of different dementia prevention approaches can be studied in relation to amyloid status. Our second project is an already ongoing observational study, risk factors of cognitive decline in elderly population. So as you probably know, there are no effective pharmacological and non-pharmacological treatments. Our best chance is just to slow down the progression. That's why to eliminate the risk factors and developing lifestyle-changing intervention programs is currently our best chance to prevent. That's why our aim is the identification of the risk factors, like and clarifying the role of cardiovascular disease, diabetes mellitus, and late-onset depression, and other biological factors like the already mentioned proteins and neuroimaging changes. We investigate two populations, the cognitively unimpaired and MCI subjects. The exposure, of course, the lifestyle risk factors like the cognitive and physical activity, the already mentioned medical condition, MRI changes, and laboratory values like the cholesterol levels, blood sugar levels. And the outcome is, of course, the conversion to dementia. Shortly, the clinical research implication is the prevention of dementia. This is a multi-center study. We, at the Semmelweis University Psychiatry Clinic and the National Institutes of Psychiatry and Neurology and Neurosurgery are the two centers. And until now, we enrolled over 120 patients. There you can see our protocol drafting. We exclude patients aged less than 50 years, and shortly we exclude patients with serious psychiatrist and or neurologist disorders. Our primary outcome is the conversion to dementia, of course, and the secondary outcomes is the rate of cognitive decline to identifying the relationship with different risk factors and different subtypes of dementia. We would like to evaluate the performance of the risk estimation scales in our population, and we would like to help in the developing a prevention program. Here you can overview again our two projects. And thank you very much for your kind attention. I'm happy to answer your questions.
Thank you for your presentation. In your first topic, you have a lot of articles involved in the analysis. How many of them were involved in the meta-analysis part, and how many of them were just involved in the systematic review part? And what was the reason if you cannot use them in the meta-analysis part? What was the main reason? Thank you.
Thank you very much. The main reason is they express their outcomes very different ways. The duration of the follow-up is different. It's from 1 year to 15 years, could change. Somewhere they express the overall hazard ratio or just the odds ratio to 1 year, 2 years, 5 years. So it's hard to pull them together.
Zsolt, what is the price of the amyloid test, and would you recommend, so if these results will remain as they are at this moment of time, can it become a screening tool and for dementia progression?
I recommend highly.
Highly. And is it an expensive?
There are two techniques: the PET scan, which is more than $500,000 Hungarian forint for one scan, but the not too expensive one is to measure directly from the cerebrospinal fluid. Is I don't know the overall cost, but it's not generally used, but a lot of different studies use this technique. And why I recommend? Because we need to know what kind of what subtypes of dementia we are looking for, and if we recognize this is a highly risk patient with pathological amyloid levels, we should start the treatment, and we shouldn't wait that he or she progress to the level of dementia.
Yeah, because I mean, you could perform a cost effectiveness analysis. Because if we started, I mean,
yes,
it would be extremely important, I think, to sell the results.
Do you know any pharmacological technique to decrease the elevated amyloid level or p-tau level?
There are just new mononuclear antibodies. It's not in Hungary, but in the US. It's yeah, we will see how effective it is. It's just since 1.5 years.
Thank you very much.
Thank you very much.
Zsolt.